All right, guys, thanks for coming. We know it's been a long, long day, but this is one of the things I am truly obsessed with. So I love sports medicine. I've been doing it for the past 5 years with the military, and then we opened up our business. So about 2 years now doing this on my own. Okay, so the first thing I really want to talk about is our approach. So I was trained traditionally as a DO, went to medical school through the military, and one of the most kind of eye-opening experiences I have had has been working with my partner who's a naturopath. So it has only advanced my approach to sports medicine care. So we're now taking just a whole new look at sports injuries that's not just diagnosis and treatment. So that is definitely the first part. So what we do here is we start with a functional assessment. What does that mean? That means we're going to get into the way you're moving. A lot of us play sports. A lot of us have injuries. We're all going to be just a little bit maybe asymmetric in something. So we always start with that to see what exactly is going on. The second thing I do is my diagnostic ultrasound. So this was something I picked up a couple years ago, and again, has been one of those really eye-opening things that now I don't have to depend on a physical exam that has plus and minuses, right? We're not quite sure, nothing's 100% sensitive. Now I get to pair that with diagnostic ultrasound, which lets me look directly inside. Unlike an x-ray, I'm able to see soft tissue. I can see muscle, I can see tendon, I can see nerve, and bone, okay? So I'm able to get all of this insight very close to what an MRI is, or sometimes better in certain diagnoses, with an ultrasound. The next thing we take a look at is the treatment. So, right, we got diagnosis, and then we go immediately into treatment. Again, the ultrasound comes into play in that I get 100% accuracy of treating what I want to treat. I don't have to do palpation or be like, okay, things should be here and palpate. I get to see exactly where my needle is going, and we're going to show you guys that today. The second thing that I do is care that's kind of supporting the injury. So when we get injured, a lot of stuff goes on that messes with the surrounding muscles, the surrounding fascia, the surrounding nerves. And so that's where my dry needling, my cupping, my manual therapy comes in to not only treat the specific site of injury, but everything else that has been manipulated by that injury. Okay, and the last, really most important step is getting from that injury state into a strength state. One of the most impactful things that I learned when I was young, I rolled my ankle in college, and my athletic trainer said to me, when you do rehab the right way, that weak side becomes the strong side. And that has always been my intent with anybody injured. The goal is that whatever you injured becomes your strong side because you devote so much strength and conditioning and rehab to that side. A lot of people will come to me and they'll say, well, this is my weak side. This is my injured side. It's not supposed to get strong. That's wrong. It should eventually get stronger than your strong side. All right, so I want to go into a little bit the power of diagnostic ultrasound. So the first thing is they have become so portable now, you can even play them on your iPhones. Okay, so you don't have to go to a big MRI machine, you don't have to go get an x-ray. We have brought the ultrasound into the hands of your physician. So what that means is, as a doctor, I don't have to refer out, unless it's something that's very complicated. I can do probably 80% of the diagnostics I need with my ultrasound, and that other 20% is when I know I need an MRI or an x-ray, and I can send out. But a lot of that stuff I'm able to keep in-house and treat right there. Dynamic, so another kind of personal anecdote is I actually tore a ligament in my thumb, and for the longest time, nobody thought anything was wrong. I could not pick up a bobby pin when I first got injured. And it wasn't until I actually had an MRI done. They couldn't see anything was wrong. They did an x-ray that's kind of in motion, where they can actually move a joint while they're taking a bunch of x-rays. And basically my joint was coming out of socket. Okay, so they're like, oh yeah, something is clearly wrong, but an MRI missed it, right? So the dynamic aspect of ultrasound, where I can make people fire a muscle or I can move a joint under ultrasound, allows me to get a much better diagnosis of potentially some things that imaging can miss. All right, and then like I said, accurate diagnosis and treatment. I get to look directly inside. I get to pinpoint. You can tell me, hey, I have pain here. Great, ultrasound. What's going on there? So we get to get that kind of 100% accuracy and look right inside the body. All right, what can it diagnose? So I get this question a lot. The easiest, most common thing is a tendinopathy. So things like golfer's elbow or tennis elbow are probably the most common things that people come in and say that they're coming in for. Plantar fasciitis is another big one. So anything where there's a tendon injury, ultrasound picks up really, really well, and sometimes before MRI. Joint swelling or cysts. So in this video right here, we actually have some joint fluid in the knee. Let's get my little laser up. So right in there, in that area there. So can really easily pick up joint fluid, Baker cyst, ganglion cyst, the one in the wrists. All right, so ultrasound is great for fluid. Muscle and tendon tears. So I've seen a couple people really post-injury. I've had a tricep tear, an Achilles tear, a bicep tendon tear. Ultrasound picks it up pretty much right away. We can start treatment right there. Getting a stat 24-hour MRI is really difficult sometimes. So this allows us to go, hey, we need that MRI right now, and ortho next day. Mainly we need the MRI because orthopedic surgeons don't like ultrasounds yet. Okay, and then nerve entrapments. So this is one that I think people are less familiar with, but I actually have a non-surgical option for a carpal tunnel. You don't have to get that released. So we can go in there with fluid, release up a nerve, totally non-invasive, just a needle, and treat people's carpal tunnel. So I've done a lot of carpal tunnel hydrodissections and have had great results where people have never come back. Okay. And then the benefits of ultrasound-guided injection. So one of the biggest things that we have with regenerative injections is that they really need to be put at the site of injury to get benefit. I know a lot of people out there getting regenerative injections where the needle is just going in blind, but you really need to target where the tendon is torn or where the muscle is torn. The needle needs to go directly there because that's where you need to put the healing factors. So in this video here, we're doing a little tenotomy where we're going right into the site of a tear, okay? The next thing we have is joint aspirations. So again, I can put my needle right into where the fluid is and pull it out. One of my experiences when I was in residency was I was on ortho, and we had someone who clearly had a joint effusion in the knee. And the ortho resident missed 4 or 5 times and could not pull out the fluid. This was before I knew anything about ultrasound, and we just assumed that, oh, maybe we're wrong. Maybe the prior imaging is wrong. We can't tap anything out of this knee. They just needed to know where to go, right? And a lot of times too, like my needle will get stuck in fat or something, and I'll have to get it out of that fat pad to get back into the fluid. So those things, having that dynamic exam is what makes ultrasound really, really effective. I will only aspirate if it's causing restriction in range of motion or pain. If someone has a joint effusion and there's no pain, then I just leave it. Okay, so getting into some of my treatments, we like to call it body priming here because it encompasses a lot of different types of treatment. So the first one is myofascial decompression. That's the fancy name for cupping. So what we do here, there are both passive and active forms of cupping. This is more of a passive approach where someone has a lot of muscle tension, fascial tension. The cupping is able to go in there and help release that, right? I know it's not going to make them completely better, but sometimes we need to increase that range of motion to get them moving better. The next thing we have is red light therapy. Again, this is another passive treatment that I just like to add on. This is more of like decreasing some of the surrounding inflammation. There's also a heating effect to it, so especially with muscle spasms, red light therapy is really effective. Okay, and dry needling. This one ends up being one of my favorite treatments. A lot of people have a lot of pain that is just a muscle that needs to be released. Dry needling goes in there and is able to basically tells that muscle to release from direct stimulation. The other thing it does is that actually triggers the body's own healing response to come in and start to heal that area. So this is a therapy that I use before PRP is just dry needling into an injury. Sometimes the body just needs a kickstart. It just has kind of given up on something, and you just need to remind it to go back there, and that's where dry needling comes in really handy. Okay, trigger point injections. This is where I actually take some lidocaine. So when we have a really, really bad spasm, trigger point injections come into play. They can go directly into the muscle, and basically I'm trying to tell that muscle to like quiet down. We take that lidocaine, which is a numbing medicine, inject it directly into muscle, and a lot of people like directly after a motor vehicle accident or like a lifting and their back locked up, if they get to me within the next like 24 to 72 hours, I can do a lot of damage control to where they can keep moving and not be out for the count for a couple weeks. Okay, next getting into functional rehab and strength training. So this is that part where a lot of people miss this step. So they get the diagnosis, they get the fancy treatment, and then they're like, cool, I'm done. The most important thing we can do is start to strength train and rehab that injury. That the goal here is that again, that side becomes stronger and we don't continually re-injure that spot. Okay, just going over a little rehab here with this guy. All right, so I like to kind of think of rehab in this sense of this progression. A lot of people, injury, treatment, rehab, but they miss that strength training, and next is performance. So there are people who come to me and they're like, hey, I've done a lot of strength training, but I keep rolling my ankle. So the next step, really, if you're really gonna get to that next spot, is that we do some performance. So we need to get into dynamic, plyometrics, sport-specific stuff, okay? So ankle injury is a great one where people will do the banded rehab, they'll start to do their balance drills, and then their PT will say, okay, we're done. But they never got back to jumping, to kicking, right? To all of these dynamic things that we are asking our body to do, and they continually get re-injured. This is Nevaeh, by the way. All right, and then the last thing is really kind of what the naturopathic medicine has brought into my care. So now I'm starting to approach injury not only like at face value, but what's going on under the system. Is there some type of underlying inflammation or process that the body is going through that's not allowing it to send its healing properties to the injury? They're being diverted to, let's say, like a rheumatoid arthritis, right? Or some type of underlying infection that is using all of the supply that you need to heal. The other thing that I've really gotten into is nutrition, muscle building, and protein building, ligament strengthening. So all of that comes with our diet. A lot of people that I see are under fueling. You can't expect to heal your injury if you don't intake the things that you need to take to cure. When you are in an injured state, you actually require more fuel than at your normal status. And what do athletes do, or a general population person do when they get injured? They eat less, because they're like, I'm moving less, so I should eat less. The reality is your body needs more to actually heal. So, funny anecdote, our cat got hit by a car, he's okay. He had pins put in, and he was ravenous. He was eating all day, all day, all day. He knew what to do as a cat. He wasn't listening to anything else inside his brain, but like, I need to recover. So he would do his little laps, and then he would eat all day, and he's better. So it's like, I watch this cat, and I'm like, he knows how to rehab himself. Like, this is wild. All right. Okay. Huh? All right, and then the last thing that I really like to get into is a comprehensive lab analysis. So for me personally, I was doing the Open last year, which was CrossFit, and I did 2 workouts. I felt like I was really, really fit. And in both of these workouts, I felt like I had an asthma attack. And I'm like, man, what is going on? Like, I've trained so well. Why is this hitting now? Flash forward to a couple months later, I get my labs done, and I was iron deficient pretty badly, almost to the point of being anemic. And that played a huge part into my fitness. So I started supplementing iron, no change in my activity, and I was all of a sudden performing better, right? So we have sometimes these underlying things that are impacting us where we want to wait till you're diseased or you're older than 45 before I'm allowed to draw labs. That's kind of one of those things. We're trying to catch you early. We're trying to optimize you at a young age so that we don't have to wait till disease shows up. We can prevent it. All right, we can get into our live demo. Any questions? Yeah.
The photo that you had with the cupping and the red light, do you actually see a bigger difference when you're pairing those modalities? Or like if you just did red light without the cupping or just like the cupping without the red light?
I'd say like the red light, sauna, ice bath, those things are going to be the most passive. The cupping is actually going to start to spread the fascial layer. So like getting your hands in there is going to be like that next step. Putting a needle in is the third. Do I do them in isolation to see? No, I have them all here, so I just throw them all in.
Yeah. And then my other one is with the PRP. Is it that you're peppering it and injecting at the same time, or is it pepper and then you go back through? Or
Yeah. So when we're doing PRP, if it's more chronic and not an acute tear, then you have to go in there. Those fibers that used to be linear, a tendon should be nice and linear. That's where all our strength is. It's healed in a ball. And so I have to go in with a needle to re-injure that area so that then the rehab can come in and the PRP can come in and promote that tendon to get to linear again.
And how do you load immediately after, or are you like waiting like a week and then?
So I'm much more aggressive with my PRP because I have had a lot of athletes who are really in tune with their body, and so they know what pain is bad pain. So usually the next day, if possible, I'll start them on isometrics, which is just a limb on contraction, basically. So we want to start to create the load on the body as soon as possible.
Okay. Cool.
Yep. Anything else? No? All right, so we'll set up for the live demo.
Let's give Katie a round of applause.